Good morning, everyone, and welcome to day 2 of ENDO 2022. My name is Colleen Williams, and I'm the Senior Communications Manager at the Endocrine Society. For today's news conference, we're going to focus on the latest in diabetes research, and we're super excited to be unveiling our new clinical practice guideline on the management of hyperglycemia in hospitalized patients. We are pleased to have with us today Dr. Mary Korytkowski of the University of Pittsburgh. She is the chair of the panel that wrote the guideline. We have Dr. Y.M. Melody Cheung of Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. We have Claire Lee of Carle Illinois College of Medicine in Champaign, Illinois, and Dr. Geethika Thota of St. Peter's University Hospital and Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Over the next 30 minutes, each speaker will present their findings, and then we will end with a short Q&A. Please note that this news conference is being broadcast live via webcast and that there are many journalists online with us right now. Because we are broadcasting via the web, it's important for all remarks to be made into a microphone so that those who are joining us virtually will be able to hear what is being said in this room. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and we'll address them during the Q&A portion. I would now like to invite our first presenter, Dr. Korytkowski, to speak.
So thank you for this invitation to present the release of our guideline on management of hyperglycemia in hospitalized patients in non-critical care settings. This has been a multi-authored process that has taken place over the past 3 years I won't read through all the names here just in the interest of time, but there were 11 of us involved from across the country as well as Europe. We had representation from adult endocrinology, internal medicine, primary care, nursing, pharmacy, and diabetes education, as well as a patient representative, which really helped strengthen this process. We also had an expert in evidence-based clinical medicine, Dr. Murad, and a health service methodologist, Nancy Santesso at McMaster University, and then the assistance of people from the Endocrine Society, many of whom are here today, Andrea Hickman, Maureen Corrigan, and Christopher McCartney, who was not able to be here this morning. We also involved other organizations besides the Endocrine Society in putting together this guideline. This includes the American Association of Clinical Endocrinologists, the American Diabetes Association, the Association of Diabetes Care and Education Specialists, the Diabetes Technology Society, and the European Society of Endocrinology. We had a representative from the American College of Physicians, and we also had a representative from the Diabetes Patient Advocacy Association. So the purpose of this guideline was to update prior recommendations from the 2012 Endocrine Society clinical guideline that addressed this topic. But now, with this approach, we used an improved methodology that adheres to the Institute of Medicine standards. We also wanted to address evolving strategies for inpatient glycemic management that facilitate the ability to achieve previously recommended glycemic goals, but while also reducing the risk for hypoglycemia, and this includes inpatient use of insulin pump therapy and inpatient use of continuous glucose monitoring, among others. And we also wanted to provide guidance for areas where there is wide variability in clinical practice that include recommendations for preoperative glycemic goals, as well as when the use of correctional insulin, well known as sliding scale insulin, may be appropriate to use and where it is not appropriate to use. So why is this important? This is important because people with diabetes account for 25% of all hospitalized patients. It's going to vary by geographic area and by location. Another 12% of patients often have hyperglycemia without previously known diabetes. These patients get admitted to every inpatient service in the hospital, meaning that every clinical service will encounter this group of patients, and their glycemic management can have a major effect on their outcomes. both short-term and long-term outcomes. We also know that despite the large number of these patients in the hospital, there is a lot of variability in either how well or how poorly their glycemia is managed when they're in the hospital. So we chose 10 topics to address in this guideline. These include the use of continuous glucose monitoring as a guide to inpatient glycemic management, recommendations for scheduled insulin therapy in patients receiving glucocorticoids, which we know are associated with significant hyperglycemia, as well as those receiving enteral nutrition. For identifying patients who may be candidates for continuing use of insulin pump therapy that they are using at home and when it is safe to use this in the hospital. We also wanted to address this issue of diabetes self-management education in the hospital. We know that it is recommended for people in the outpatient setting, but often they do not get this. And we were able to observe that this can also impact long-term outcomes in these patients. Another topic that was addressed is where should glycemic goals be for people who are undergoing surgery, with the suggestion that HbA1c levels be less than 8 and preoperative glucose is less than 180 to improve postoperative outcomes. When carbohydrate-containing beverages can be and cannot be used preoperatively. We also addressed the issue of using non-insulin therapies in the hospital, and as I mentioned earlier, when correctional, otherwise known as sliding scale insulin, can be used, and when correctional insulin used alone should never be used in people with diabetes in the hospital. So what do we hope the future impact of this guideline will be? Well, we hope that it will resolve debates regarding appropriate preoperative glycemic management. We hope that it will resolve the debate about when sliding scale insulin can be used and should not be used. We also hope that it will stimulate research funding for this very important aspect of diabetes care. And we also hope that hospitals will recommend the importance of having access to knowledgeable diabetes care and education specialists who can provide staff education regarding inpatient glycemic management, provide oversight for patients using insulin pump therapy or continuous glucose monitoring devices, and empowering nurses to provide diabetes education prior to patient discharge. Claire Pegg was our patient representative on this committee, and this was her quote, which I feel is very important and really sums it all up, that it was her hope that this guideline would serve as the beginning of a conversation that will allow inpatient caregivers to provide individualized care to patients, some of whom may be very self-sufficient with their glycemic management, and others who need additional assistance. The importance of these conversations cannot be overemphasized. I thank you all for your attention.
Thank you so much, Dr. Korytkowski, for that wonderful presentation. I would now like to invite Dr. Cheung to present.
Thank you. Good morning, everyone, and thank you again to the Society for this opportunity to present our work. So today, I'll be talking about the effects of diabetes and glycemic control on cancer outcomes in individuals with metastatic breast cancer. And it's my privilege to be presenting on behalf of my co-authors from the Brigham and Women's Hospital and the Dana-Farber Cancer Institute, where this work was conducted. So this study was funded by Lilly. With regards to the background, it is well established that a complex relationship between breast cancer and diabetes exists. Approximately 10 to 20% of all postmenopausal women with breast cancer have pre-existing diabetes. We know that both diabetes and breast cancer share similar risk factors, including increasing age and obesity. Furthermore, many of the novel breast cancer treatments, such as immune checkpoint inhibitors and PI3 kinase inhibitors, have also been associated with the development of diabetes and hyperglycemia. However, to date, there has been little research conducted on the effects of diabetes, and in particular, on the impact of poor glycemic control on breast cancer outcomes. Finally, given the impact of metastatic breast cancer on life expectancy, Existing studies have primarily focused on patients with early disease, and there have been no studies specifically within metastatic breast cancer patients. So recognizing this gap in knowledge, the aim of this study was to determine the effects of diabetes and glycemic control on disease progression and mortality in individuals with metastatic breast cancer. So we identified all patients diagnosed with metastatic breast cancer at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute between January 2010 and January 2021 using 2 institutional databases. Patients were grouped based on diabetes status. And for risk adjustment, we created 2 groups of patients that were matched for age, sex, and ethnicity. And this resulted in 244 matched pairs. Our outcomes of interest were firstly overall survival, and secondly, time to next treatment, which is basically a surrogate measure of cancer progression and is defined as the time interval for a patient to transition from a first-line metastatic treatment to a second-line regimen due to documented progression of disease. We also performed subgroup analyses based on glycemic control, and the definitions based on random blood glucose and hemoglobin A1C measurements are listed here. So this table reports the baseline characteristics of our cohort. As you can see, diabetes and control groups were well balanced for age, sex, ethnicity, and hormone receptor status. The median age was approximately 57 years for both groups. Almost all were female, and over 84% were white. Type 2 diabetes was the most commonly reported diabetes diagnosis, and glycemic control over the follow-up period was worse in the diabetes group when compared to the control group, as we would expect due to the study design. So here you can see that overall survival was comparable between diabetes and control groups at 5 years. Similarly, time to next treatment was also similar at 1 year between the diabetes and control groups. A subgroup analysis was then performed based on patients' glycemic control as previously defined, and no difference was observed between glycemic subgroups for overall survival at 5 years or time to next treatment at 1 year using either of the glycemic definitions. So while no difference was observed in overall survival between the diabetes and control groups, visually you can see that there is some separation of the curves at approximately 8 years. So we then performed a landmark analysis whereby we specifically investigated the survival of patients who lived beyond 8 years after the diagnosis of metastatic breast cancer. And we found that at 10 years, overall survival was better in controls when compared to the diabetes group. Similarly, at 10 years, overall survival was also better in those with good glycemic control. So in conclusion, these data provide some reassurance that in the first 5 years, glycemic control may not be a major contributor to overall mortality or cancer progression in most individuals with metastatic breast cancer. However, specifically in longer-term survivors, diabetes and poor glycemic control were indeed associated with worse survival. As the clinical impact of diabetes may only be felt over this longer period of time, active management of glycemic control may be most relevant for patients who have better prognoses. Individualized diabetes goals and strategies, taking into account patient prognosis, should therefore be considered in patients with metastatic breast cancer. Thank you.
Thank you so much, Dr. Cheung. I would now like to welcome our next presenter, Claire Lee, to the stage.
Hello and good morning, everyone. First off, I'd like to thank the organizers of this event for this opportunity and also you all for being here today. I'm really excited to discuss with everyone our work titled Nationwide Geospatial Analysis of Hospitalizations and Diabetes Mellitus Complications. I'll briefly mention that I have no financial conflicts of interest or disclosures with the following presented material. So there have been substantial public health efforts devoted to understanding the factors that underlie poor health outcomes in patients with diabetes. According to the CDC's most recent National Diabetes Statistics Report in 2020, there were approximately 40 million Americans with diabetes, and I'm sure that this number has only risen over the past couple of years. Diabetes and its complications also represent a significant source of morbidity within the U.S. In fact, diabetes is ranked 8th among the top 10 leading causes of death, and its most common complications, including heart attack, stroke, and kidney failure, also happen to be among the top 10. So given the prevalence and impact of this disease, my team at Carle Illinois College of Medicine wanted to target potentially significant geospatial disparities in diabetes complications among Medicare patients. Then based on the results, if there do happen to be disparities, we wanted to address if there were any potential socioeconomic, cultural, and medical attributes that distinguish these adversely affected communities apart from others. So I'll start by running through our workflow process. First, we gathered information from publicly available databases, including the U.S. Census, Center for Medicare Services, the National Plan and Provider Enumeration System, and the United States Department of Agriculture. The main indicators of diabetic control we chose to focus on were a few of Center for Medicare Services Prevention Quality Indicators, or PQIs. So we looked at PQI number 1, diabetes short-term complications admission rate, with short-term complications being diabetic ketoacidosis, hyperosmolarity, and coma. We also looked at PQI number 3, diabetes long-term complications admission rate, with long-term complications being more systemic, renal, eye, cardiovascular, and neurological problems. And lastly, we looked at PQI number 16, lower extremity amputation rate, among patients with diabetes. So we combined all that data into our own data set, which was then cleaned using Python and exported to Geota. Geota is a geospatial analysis program that allowed us to visualize diabetic complications on a county level. That analysis was then supplemented with Moran's eye, a measure of spatial autocorrelation, or a measure of how one object compares to those surrounding it. So that allowed us to identify statistically significant geospatial hotspots, cold spots, and potential outliers. So then ANOVA was conducted across all of our groupings, followed by a two-tailed t-test between hotspot and cold spot groups to identify what socioeconomic, cultural, and diabetic management attributes stood out between these geostructures. For example, we looked at minority representation and the number of endocrinologists in these areas, percent in poverty, percent uninsured, and other comorbidities, just to name a few. So let's move on to the results. Starting with long-term diabetes complications, the geospatial visualization revealed an expansive hotspot cluster that encompassed the East Coast and much of Florida and Texas. And we can see that in red. Conversely, a cold spot cluster was located in the West and Great Plains region in blue. As for short-term complications and lower extremity amputation rates, similar geospatial patterns were observed, but there was a caveat. We discovered a new hotspot cluster within California and the West Coast, which we thought was very interesting. We aren't sure why that is at the moment, but that's definitely something we want to look further into. So we as scientists typically expect there to be higher diabetic complications along the Southeast region. When we look at adult obesity prevalence maps, for example, we typically see the same patterns as well. But what is not fully understood is what makes these hotspots hotspots and cold spots cold spots. So we performed further data analysis using ANOVA, which revealed the differences between these hotspot and cold spot clusters. And what we found is that hotspots tend to have greater Hispanic representation, up to 6.7%, and Black representation, up to 10.9%, compared to cold spots. Hotspots also appeared to have greater population density of over 124 persons per square mile and a greater number of endocrinologists per capita. Some might think that having more endocrinologists in a certain area would lead to better health outcomes in diabetic patients, but we think that there are more specialists in these areas because of the higher prevalence of diabetes. I should also mention that a lot of the other variables we looked at, including other comorbidities like heart disease, hypertension, and stroke, were also clinically significant, but they were so on a lesser scale. Interestingly, the variables that didn't appear to make significant difference between the hotspot and cold spot clusters were percent in poverty and percent uninsured. Typically, when we consider social determinants of health, these variables are huge factors in measuring health outcomes, but the fact that they were not significant in this particular study is very intriguing. So in summary, we see that there are well-circumscribed regions of the US that are adversely affected by diabetes complications. Certain demographic populations, particularly Hispanic and Black communities, seem to be more at risk for developing them, but others, such as uninsured individuals and those in poverty, do not appear to be at significant risk based on our study. So what do we do with this information? Well, if you recall the geospatial graphs from earlier, California, along with other parts of the West Coast, had higher rates of short-term diabetes complications. In general, the prevalence of diabetes along the West Coast are relatively low compared to other regions. So why do we see this region as a hotspot specifically for short-term diabetes complications and not long-term ones? That's definitely something we want to explore moving further. In general, this means that we need to keep the West Coast on our radar for being an at-risk region to prevent further increases in long-term complications. It also isn't much of a surprise that Hispanic and Black communities were correlated with higher rates of diabetic complications. We see that in general, these groups often experience health disparities due to a combination of factors, including lack of access to healthcare, lower socioeconomic status, and different cultural attitudes and behaviors, which can all be barriers to preventative care and effective diabetes management once diagnosed. Overall, pinpointing these geographic areas where diabetes complications are more prevalent is huge. We can now increase awareness, screening, and implement more community outreach and diabetes education programs in these areas. Thank you for listening.
All right, thank you so much. And I would now like to invite our final speaker for our Diabetes News Conference to the stage, Dr. Geethika Thota.
Hello everyone, good morning. I'm Geethika Thota. I'm a PGY2 internal medicine resident at St. Peter's University Hospital, Rutgers University in New Jersey. So it's a great pleasure and honor to present our study with you all today, and I would like to thank ENDO Society for giving me this opportunity, and thank you everyone for listening to us as well. So let's begin. So our title is Prediabetes as a Risk Factor for Myocardial Infarction based on a national inpatient sample analysis. So I'm presenting today on behalf of my team, and I have no financial disclosures or conflicts of interest with the material presented today. So we all know that diabetes is a well-established risk factor for atherosclerotic cardiovascular disease. And the latest guidelines recommend high-intensity statin therapy in addition to lifestyle changes and aggressive control of cardiovascular risk factors to decrease the risk of ASCVD and mortality in patients with diabetes. However, despite mounting evidence, clinicians and also the public were not totally aware that prediabetes is also a major risk factor for ASCVD. So our objective is to study if there is any association between prediabetes and coronary artery disease causing myocardial infarction. If you see in this picture, prediabetes could be reversed back to normoglycemia, or it can progress to type 2 diabetes. And our study is to look the association between prediabetes and myocardial infarction. So the methods we utilized is a national inpatient sample. So National Inpatient Sample is a publicly available inpatient care database. It has about more than 7 million patient hospitalizations per year. And we included patients from 2016 to 2018 because that is the latest available data. And in our retrospective study, we included adults more than 50 years and who were admitted to the hospital or teaching hospitals with primary or secondary diagnosis of prediabetes. And then we created 3 separated models to see the association between prediabetes and myocardial infarction and percutaneous coronary intervention and coronary artery bypass grafting. And the variables we used to extract are obesity, diabetes, hypertension, dyslipidemia, family history of MI, nicotine dependence, all the well-established risk factors for atherosclerotic cardiovascular disease. And we used ICD-10 coding system to extract these variables. And the results. So we have a total of 1.79 million weighted hospitalizations who had MI, and about 330,000 patients had prediabetes. And out of the 1.79 million weighted hospitalization patients with MI, 1% had prediabetes. And on a univariate analysis, prediabetes was greatly associated with increased odds of myocardial infarction with an odds ratio of 1.41, and p-value is statistically significant. And then we adjusted for all the well-established risk factors like diabetes, hypertension, obesity, family history of MI, dyslipidemia, nicotine dependence. We looked into age, gender, and race. And despite adjusting all these well-established risk factors, prediabetes was still associated with higher odds for myocardial infarction with an odds ratio of 1.25 and 95% confident interval lying between 1.2 to 1.3, and the p-value is statistically significant. And not only just that, prediabetes was highly associated with increased odds for percutaneous coronary intervention with an odds ratio of 1.45, and also coronary artery bypass graft with an odds ratio of 1.95, which is even more higher, indicating the severity of coronary artery disease in patients with prediabetes. So the conclusions from our study, one thing is prediabetes stood as an independent risk factor for myocardial infarction despite adjusting for all the well-established risk factors. And the second point we found out is coronary interventions such as percutaneous coronary interventions and coronary artery bypass grafting were highly associated with prediabetes, suggesting the macrovascular coronary artery disease burden in patients with prediabetes. We do have some limitations. Prediabetes is often missed during coding. We basically used ICD-10 coding system to extract the data, and sometimes the prediabetes is often missed during coding, and we try to address this by including the teaching hospitals who try to code better. And the other thing is the majority of the patients with prediabetes are located in the community and the clinic, and our sample is from the inpatients, so the results represent only one subset of the patient sample. And obviously this is a retrospective design. So the discussion. So with our study results, we would like to reinforce that it's a wake-up call for the clinicians as well as the patients to shift the focus to prevent prediabetes and not just diabetes. And our findings would also reinforce the importance of early recognition through screening and early intervention to aggressively manage the cardiovascular risk factors to prevent myocardial infarction. And we do have some recommendations and early recognition through routine screening. These are the guidelines from the latest American Diabetic Association Standard of Care 2022. Screening for all the patients aged more than 35, and in adults with overweight or obesity with BMI of more than 25 or more than 23 in Asian Americans with any of the following, which include first-degree relatives with diabetes and high-risk ethnicities like African American, Latinos, Native Americans, Asian American, and Pacific Islanders, any previous history of coronary vascular disease, hypertension, hyperlipidemia, PCOS, physical inactivity, and conditions associated with insulin resistance like severe obesity and acanthosis nigricans, etc., and women with gestational diabetes mellitus, and people with HIV who are on antiretroviral therapy. And the recommendations. Most important things to focus are the early intervention is the key, and the most important recommendations from our side is diet and physical activity. Physical activity of at least 150 minutes of moderate to vigorous intensity or minimum of 75 minutes of vigorous intensity exercise, and lifestyle modifications to address the other risk factors for coronary artery disease, for referring to tobacco cessation program, etc. And medications, always weighing the risk and benefit. If needed, metformin and GLP-1 receptor agonists could also be used. So with this, I would really want to highlight again that prediabetes is real, and don't let the pre fool anyone, and it's a call to action. Thank you all, and thank you once again for your time and attention. Thank you.
Thank you so much, Dr. Thota, and to everyone who presented today. We're now going to begin our Q&A portion, so I'll turn it over to my colleague Jenny to read a few questions from any journalists. Remember to please include your name and outlet along with your question.
Hi, I'm Jill Roulette from Helio Endocrine Today. My question is for Dr. Cheung. Did you look at any medications associated with the people with diabetes, like who was taking what, if that had any difference?
Yeah, that was a great question, and it is something that we did look at. So we broke up the classification of diabetes based on different types, as well as the medications that may have induced diabetes. So we looked at steroid-induced diabetes, as well as the PI3 kinase inhibitor diabetes as well. And in terms of the numbers, as we would expect, steroid-induced diabetes was a large proportion of the patients, but surprisingly, PI3 kinase inhibitors, which only became available through the FDA in 2019, also made up a relatively large proportion. So it's a growing area of need, and I think we're going to need to be more aware of patients developing diabetes from PI3 kinase inhibitors as well. In terms of your question regarding does it affect overall survival, this is something that we didn't look into due to the smaller numbers of our cohort. So I think the numbers we have would not be sufficiently powered to show a difference.
Great. I have a question in the online chat for Dr. Korytkowski. This is from Marlene Busco with Medscape. She asks, the guidelines suggest the use of CGM devices in patients in non-critical wards where resources and training are available. Are CGM devices approved by the FDA now? And she notes there was approval during the pandemic, and now there's a breakthrough designation. What are the funding, safety, and training barriers to in-hospital CGM device use?
Is this on? Thank you for that question. That's a really good question. And we were actually very careful in terms of looking at the data. CGMs are approved for use in the outpatient setting, and there is an increasing number of people using CGMs in the outpatient setting, and it's actually becoming the standard of care there. The FDA did not approve use of CGM in the hospital setting. They allowed the use of continuous glucose monitors in the hospital setting during the COVID pandemic. They published an allowance in April of 2020 when everyone was scrambling for what to do. There was a shortage of personal protective equipment, and there was a real interest in trying to limit the amount of exposure healthcare personnel had to some of these really critically ill patients for whom intravenous IV insulin therapy was used to control their glucose levels. The IV insulin infusions require hourly glucose monitoring, so these continuous glucose monitoring devices could be used to provide remote information about trends in glucose levels over time. So these are not currently approved for inpatient use, so we were very careful in writing this guideline. And the way the allowance was stated is that they be used to detect trends in glycemic management, but for making decisions about actual insulin dosing, that be done with a point-of-care glucose measure, which remains the standard of care. The issue about do hospitals have the resources available to implement these devices is an excellent question. It is something we address in the guidelines. We did include some criteria that would need to be in place, including extensive staff and nursing education to have people with expertise available to provide support to nursing personnel who are both placing these devices, changing these devices, looking at trends, and then knowing when to remove them for certain procedures such as MRI or radiologic procedures. So there is a lot involved in doing these. We know that not all hospitals may be readily available to use these, so it is an area of active research, but the use of these devices during the pandemic, in both critical care and non-critical care settings, has really provided us with a lot of information that was used to formulate this suggestion in the guideline.
Thank you. Ms. Lee, if you could answer, what can be done to address some of these regional hotspots? Are there steps that healthcare providers or individuals can take?
Yeah, so I addressed some of this earlier in my presentation. I think that the best way to address these hotspot clusters are more outreach, community outreach programs, diabetes education programs, and just increasing the overall awareness, I think will have a huge impact. But as for clinicians, I think we just need to be aware of this fact, and we'll leave it up to the public health specialists to decide what more we can do.
Great, thank you. Dr. Thota, how can we get more patients and clinicians to prioritize prediabetes, care and prevention?
Yeah, thank you for the great question. So at the level of clinicians, so we would like to recommend more emphasis on medical education at the level of primary care, family medicine, who are involved in the patient care. More emphasis on how the hazards of prediabetes, on what hazards are there for cardiovascular diseases. And at the level of public, awareness creation is the key. So we have to create more awareness, we have to counsel them. So this is what it is, these are the hazards of prediabetes, and this is the time to action. And that's how we would like to recommend, yeah.
Wonderful, thank you. That is all the questions we currently have.
Great, thank you so much. With that, thank you so much to all of our speakers and the journalists who took the time to join us today for this super fascinating discussion. As a reminder, recordings of these news conferences will be available on our website and YouTube channel. If you have any additional questions or would like to set up an interview with one of our experts, please contact us at media@endocrine.org. Thank you again for your time today.
Thank you.